We have many health advocacy groups that will come to talk to us about a variety of respiratory illnesses that are affecting communities of color, including COPD. Still on? Okay. Including COPD, which is the third leading cause of death in the United States. And what has been very striking for us to learn is that how many of these diseases are environmental. You know, at this conference we tend to talk a lot about our lifestyle choices, you know, eating healthy, exercising, those sorts of things. But what we realize in our office is that environmental concerns are very serious. And particularly in Chicago, where we've had very high rates of respiratory illnesses due to environmental factors. So as we all know, the quality of air that we breathe not only affects our quality of life, but it can be life-threatening. So with us to unpack all of these things, talking about lifestyle, environment, inadequate access to health care, are today's panelists. And they have a lot of very good information to share. So first is Dr. Alvin Thomas Jr., and Dr. Thomas is an associate professor of medicine and the chief of the Division of Pulmonary and Critical Care Medicine at Howard University. He's also the chair of the Health Equality Subcommittee of the American Thoracic Society. Also with us is Dr. Walter Conwell. Formerly of Chicago, he had the nerve to leave. A Gary, Indiana native, so I'm going to make sure I get that straight. And was from the University of Chicago. He is now the inaugural administrative fellow in the Office of Diversity and Inclusion and a clinical fellow in the Division of Pulmonary Sciences and Critical Care Medicine. His clinical interest is focused on the care of patients with severe respiratory and sleep disorders. His research interest is focused on the effect of dietary macronutrients on sleep, weight, and activity. So today, our doctors are going to be talking to us both about general respiratory illnesses and sarcoidosis. And I'm going to turn this over to Dr. Thomas first. Oh, one last thing. So we'll have presentations from both of our panelists, and then we will open it up to questions.
Thank you, Ms. Whistle. It's a pleasure to be here at this meeting of the Congressional Black Caucus. Certainly the issues of disparities are major for this country more than ever before. And you all may, you know, the cardiac and vascular and cancer disparities get the press, but the respiratory and critical care and sleep disparities are substantial. I'm a member of a group of physicians calling ourselves primarily pulmonary docs, but most of us also do critical care medicine and sleep medicine. And so you'll hear Dr. Conwell and me talk about those various illnesses. I did not prepare slides. I was asked to give a handout, and so I think I gave most people handouts here, but those who have not had a handout, if you raise your hand, I can get you handouts, so at least 3 people. As you can see in my introduction on my paper, I was fortunate to see an article in the April 14th, 2015 issue of the Journal of the American Medical Association. Actually, there were 3 articles there, and I'm going to touch on a couple of them during this discussion. And one of the most interesting papers in that issue was by the editor-in-chief of the AMA Journal, and that's Howard Balkner. And in that editorial, he commented on 2 articles in the journal, one that focused on the health of young African American men, and the other that focused on how to design a healthcare system that achieves equity. And I strongly recommend that you look at all three of those, the two original articles and the editorial by the editor-in-chief, Dr. Bachner. Dr. Bachner then asked questions and made some comment that I think are pertinent and of interest to all of us who've been involved in the health disparities field. And we've been asking these questions for years. And I'll quote. I thought these comments, by the way, I was somewhat surprised at how straightforward and challenging these comments were. He says, where has the debate been about equity and disparities in health and health care? Have these issues slipped into the shadows because of health care reform? He further comments, certainly no one believes that simply extending health care to more individuals will reduce many of these disparities. Much more is needed to address the substantial differences in health status and health outcomes related to race, ethnicity, and poverty in the United States. And I would think, along with the New England Journal of Medicine, the AMA journal is probably one of the most circulated journals in the world, and certainly in this country. And I think that comment hopefully will at least get the attention of more people and maybe have some impact. Now, I myself have noticed a small but increasing number of articles in our journals, a wide variety of journals, certainly the respiratory and critical care and sleep journals, over the last several years that discuss these issues related to health disparities in our most vulnerable populations. I agree that health reform may have muted some of the debate, but all of us here certainly, because we're here, know that better, for years the discussion has been about access to care, and that's clearly important. I remember when the original Institute of Medicine monograph came out several years, and then that was followed in a very short period of time by a group of articles in the Annals of Internal Medicine that I thought were quite good around the early to mid 2000s. So these issues have been before us for a long period of time. And today, Dr. Conwell and I will give you some insight into the problem of health disparities in underserved populations with respiratory diseases, those in critically ill patients who are seen in intensive care units in this country, and those with sleep abnormalities. And I want to start out with some definitions. A couple of these definitions are a little long and boring, but they are what they are, and they were put together the way they were because we thought it was necessary. I always like to, and you notice Dr. Bachner in his comments, separate the issues of disparities in two parts. One is disparities in health. In other words, people who are ill and they have and their illness is worse than others. So that's the disparities in health. And we define that. This was defined, and I give the two references in a combination of these two journals below. Number one, disparities in health. Disparities among ethnic and racial minority groups that are due to differences in the burden of diseases, death, and morbidity compared to non-minorities. They frequently are related to race and class, which are independently related to health status. Racial and class discrimination may lead to health inequality, so-called disparities. And as Ms. Wilson commented, I chair a committee. There are for those of you who are not in the respiratory area, there are two main medical societies that specialize in pulmonary and critical care medicine in this country. One is the American College of Chest Physicians, and the other is the American Thoracic Society. And I'm chair of a subcommittee in the American Thoracic Society on health equity, and we've been dealing with these issues for the last 2 or 3 years. We have some very active, experienced members, but also some younger members with a lot more vim and vigor than the more experienced members, and so it's worked out very well. And we came out with some monographs, several manuscripts in May of 2014 that were published in the Annals of the American Thoracic Society. And in that, we gave these two further definitions. One, for respiratory health disparities. And they were defined by our group as significant differences in respiratory health that are closely related to racial ancestry, social, economic, and/or environmental differences. Health disparities adversely affect groups of people who have experienced greater obstacles to health based on their racial and ethnic group, religion, socioeconomic status, gender, age, occupation, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. Now, when I saw this definition, I thought it was awfully long, but I think it's, in terms of what it includes, I think is extremely important, because it really puts the issue quite up front and broadly, and it's clearly more than just an issue of ethnicity, race and ethnicity, but race and ethnicity is certainly central to it in this country. And we define respiratory health equality as the attainment of the highest level of respiratory health for all people. Achieving health equality requires valuing everyone equally, implementing and maintaining focused societal efforts to address avoidable inequalities and historical and contemporary injustices, and eliminating healthcare disparities. I would suggest, if you have a chance, to go online to the Annals of Thoracic Surgery. I think some of these articles are free if you go through PubMed or Google Med. But I suggest you go and look at these articles. There are about 5 or 6 articles that are quite pertinent. So the question next arises, what are the primary illnesses in respiratory, critical care, and sleep medicine where there's significant disparities in health and health care? And I have them listed here just as bullet points. Dr. Conwell is going to discuss a couple of these in a little bit more depth. He's going to discuss obstructive lung diseases, lung cancer in more depth, and I think he's going to speak about sleep disorders. But you can see they're relatively substantial illnesses, and it involves a wide variety of patients. Tuberculosis, you're talking about, international people from coming to this country from outside, as well as those born and raised in this country. Sarcoidosis was briefly mentioned a few minutes ago. And the sleep disorders, it's not commonly recognized that sleep disorders, there is a disparity in sleep disorders, but there is a clear disparity. I'm sure you all, if you watch the local news in your various venues, you hear more and more about sleep issues every day and every week, that you look at your local news. This area, I call it a subspecialty. The sleep doctors certainly don't look at it as a subspecialty. But, this area is a burgeoning area. There was a lot of people didn't understand why some patients would have life-threatening arrhythmias or myocardial infarctions 2 or 3 o'clock in the morning. And we began to realize that a good number of these were due to sleep-related issues. And when you hear of these accidents on the freeway at 4 or 5 o'clock in the morning on a road that's not very busy, you wonder, how in the heck can that happen? Many of these are sleep-related problems. So it's a very substantial problem. There's a lot of lung illnesses related to HIV infection, particularly AIDS. Diseases in the critically ill are quite important. You people ask me what a critical care doctor does, and I basically tell them that they take care of the sickest patients in the hospital. And among the problems that they take care of, among the most common are people who have septicemia, widespread bloodstream, life-threatening infections. And another one I don't have listed here is respiratory failure from severe damage to the lungs. And these are clearly more common in African American and Latino populations, particularly African American. I think it wasn't known too many years ago, but the whole issue of blood clots in the legs that go to the lungs, venous thromboembolism, is a growing problem in this country, partly due to the fact that we have more effective diagnostic means with X-rays and CT scans, etc. But and it's a growing problem in the elderly, as defined by those 65 years and older. But there clearly is a difference in the prevalence and frequency of this problem in minority populations in this country. I wanted to spend a little time giving you an idea how costly these disparities are to the respiratory critical care sleep community. You can see here that, and this is this first line, the overall line, that's data from about 2008, 2009, and so those are 2008, 2009 dollars. All of the lung disease costs about $154 billion. Asthma, the most recent data I could find, about $56 billion per year. And with asthma and COPD, that involves both direct costs and indirect costs. It includes that. And with lung cancer, the most common cause of death from cancer in this country, $12.1 billion. So the underserved are responsible for disproportionate cost of care because of overuse of emergency services in particular, and rates of potentially preventable hospitalizations have been substantially higher among African American and Latino populations. And this is particularly true with asthma, COPD, and COPD. You'll see some information in the literature that suggests the incidence of COPD is lower in this country in blacks than in Caucasians, and that's been quoted for years, but many of us feel that they've not been able to get a good representative sample of the underserved communities because they're hard to reach. Change phone numbers, change cell phones, etc., and they're hard to reach and get that data. But one thing is clear, even with the data we have, that minority COPD patients utilize the emergency room more and are hospitalized more. I saw some data a few years ago from the asthma literature that if you look at the total cost of care in asthma, and I don't think this has changed a lot. If anything, it's worse because the incidence has gone up and the frequency and the prevalence in selected Latinos and African Americans is greater, but if you look at 100% of asthma costs, 80% of that cost is from 20% of the asthma patients. And those patients are predominantly the patients that don't see primary care doctors, that overuse the emergency room, and that are hospitalized. So, these data are powerful. If you look at the lung cancer data, you'll see that the incidence and death rate from lung cancer is earlier and higher in the minority populations, particularly African Americans. And the last line here is data I saw from a few years ago, and that's particularly powerful, particularly, and I have to become a little political here, particularly those who suggest that availability of health care to the underserved and continued efforts to, even if they have insurance, to reach out and get them to become a part of the health care network, that it's not that important. But you can see these inequities, the ones I mentioned above, cost the U.S. economy, and this is data from 2011, $300 billion per year. And some of you who are interested in health policy may have seen that data before. So, lastly, the question is, what do we need to do better to have a greater impact on the complex issues of disparate health and health care in this country? In that same JAMA journal from April 14th, there was an article there by Wong et al. On achieving health equity by design. And they discuss some of the issues that are particularly important and reach some conclusions. And I really believe this is the key to one of the major keys to try to reduce the health and healthcare disparities in this country. I sit on a committee on a board of directors that talks a lot about reaching out to patients and getting them on the internet and having available digital information so that they can interact and educate them. But I point out periodically what they point out in these last two paragraphs, and I'm going to read them because I think it's powerful. The Wong and Company and group says, to design services that promote health equity, there must be a clear focus on specific communities at risk, a commitment to listen and collect meaningful data, to understand local needs and priorities, a conviction to make progress and ongoing assessment of health outcomes. Healthcare systems should recognize that some individuals have concerns that are perceived as more urgent and immediate than their personal health status, such as unemployment, school failure, housing instability. Such concerns may make it impossible for medical organizations to address health equity if they do not look outside their walls for assistance. To make progress, hospitals, physicians, and others should explore partnering with community agencies to build on the assets of trusted relationships. I'll say that again, trusted relationships, insight, and visibility. Working together can not only engage patients more effectively in health where they live and work, but also indirectly mitigate factors that contribute to significant illnesses and disability. I think that's a powerful comment. I think it strongly asserts the problem. And I want to make one last comment. I had a mentor His name is M. Alfred Haynes. He was at the Charles Drew Medical Center. He is a kind of a health policy person, an epidemiologist, MD, PhD. And in the AMA Journal on August 18th, 1969, he wrote this. He has an article entitled "Problems Facing the Negro in Medicine Today." You know it was old because they called us Negroes in those days. But I'm going to make two comments. One he makes about diversity in the discipline, but the other about the issue of disparities. He said one of the major mistakes of the civil rights movement, this is 1969 now, is that integration has often been made an end in itself. Predominantly white schools should admit more black students, not merely for the sake of integration, but because the country needs more black physicians, even more desperately than it needs more white physicians. Now, you know there was a minuscule number of black physicians in those days. Unless a way can be found to increase substantially the pool of black candidates for medicine, there will not be a satisfactory solution of this problem. Recruitment for black students is necessary, but recruitment will not in itself increase the pool. It may achieve desegregation, which is an important battle, but it will not win the war. Over the long haul, the outlook is not encouraging unless we can have an impact on the educational system as far down as the elementary level. I hear us talking about these things, but we have not come close to solving that problem. And then he goes on. He was a member of the National Medical Association at that time, a predominantly black physician organization. He says, far from abolishing the National Medical Association, black physicians invite all physicians to join them in removing the barriers between government medicine and private medicine, in once and for all abolishing charity medicine, in bringing the poor into the mainstream of American medicine, and in helping every American, black or white, rich or poor, to enjoy the benefits of adequate health care. And that's in 1969. We'll be available for questions after Dr. Conwell gives his presentation. Thank you.
Hello, everyone. I want to, again, thank the Braintrust for inviting us to come out and speak. I definitely want to thank Dr. Thomas for that wonderful overview. What I'll do over the next few minutes is actually go into a little more detail about some of these issues, but specifically try and talk about practical ways to make interventions. So particularly as we consider disparities, but truly bring about health equity. But then also one of the points that Dr. Thomas finished off with, the workforce and diversity in our respiratory healthcare workforce, and how can we practically bring that about. So again, I'm originally from Gary, Indiana. I actually did undergrad at Florida A&M University, med school through chief residency at the University of Chicago, and now I'm at the University of Colorado. So I'm a fourth-year pulmonary critical care and sleep medicine fellow, but I'm also an administrative fellow in the Office of Diversity and Inclusion. So my interests have to do with translational research, particularly disparities in sleep metabolism, etc. But my administrative research actually and activities actually have to do with our pipeline and really how we can increase the number of underrepresented minorities going through our pipeline. So with that, to take a step back, there are a lot of illnesses that we deal with as pulmonologists, as really respiratory healthcare professionals. Asthma is the one that primarily comes to mind, and we've already talked a little bit about those disparities. And it's very true that there's a definite discrepancy between the prevalence of asthma within black communities and the prevalence within Caucasian communities. But what's also interesting concerning the morbidity and mortality related to this difference is fairly striking, where African Americans, particularly African American children, go to the emergency room more often. They are admitted to the hospital and ultimately to our ICUs more often. And ultimately, over the course of their lifetime, the age-adjusted death rate is substantially higher for blacks than for Caucasians. Now, there are a lot of underlying reasons why that may be. Now, one of the underlying concerns is there's a genetic predisposition that's present within African Americans versus the majority. And we've recently developed or recently have begun to understand that there are definitely, for instance, polymorphisms in the beta-2 receptor. So the beta-2 receptor is a receptor that's important for the action of agents. We call them beta agonists, so agents like epinephrine, but conventionally the agents are in albuterol inhalers. And these polymorphisms, so these differences in these receptors, actually cause these receptors to be less effective when we give these medications that we would typically give in the setting of asthma exacerbations and just routine asthma management. So that's very clear. But we also understand that African Americans, as we consider the triggers for asthma, and these would include environmental pollutants, these would include both outdoor as well as indoor pollutants. Also, secondhand smoke exposure to allergens such as cockroach allergens, dust mite allergens, dog and cat dander, etc. African Americans are more likely to be exposed to these. Now, there are actually statistics out there that African American communities are more likely to be located around high traffic areas. And the combustion from these automobiles, particularly, and also combustion from coal-burning power plants and other industrial complexes can actually severely worsen asthma control and potentially may even worsen or blunt lung development, so predisposing our children to greater healthcare disparities down the road. So that much is clear. Now, as we think about other respiratory illnesses, so particularly the smoking-related illnesses, COPD, lung cancer, and I'll even touch on SIDS briefly, we see other disparities. So as Dr. Thomas mentioned, COPD is probably one of the few illnesses where African Americans don't share a disproportionate burden. But that may, as he alluded to, have to do with sampling. But what's interesting, even though Caucasians, particularly Caucasian men, suffer from high rates of COPD, also worsening morbidity and mortality related to COPD, it's actually the interplay within African Americans, particularly African American men, that lead to higher mortality as we consider, for instance, lung cancer. So COPD is one of the primary risk factors for lung cancer, both morbidity as well as mortality. And African Americans, particularly African American men, are at increased risk of lung cancer related to their COPD. Now, for lung cancer, we also see, again, the possibility of an underlying genetic component where even though African Americans have rates of tobacco use, and as you all know, tobacco is the primary risk factor for development of lung cancer. So even though African Americans have rates of tobacco use that are equivalent to Caucasian, and in some age groups even less, they actually suffer from a disproportionate increase in lung cancer. Now, this is even seen for lung cancers that aren't associated with tobacco abuse. So particularly for women, both African American and Caucasian, there's a higher risk of lung cancer that's not smoking related. And when we look at populations, again, Caucasian versus African American women, we see a threefold increase in the risk of lung cancer for these non-smoking related malignancies. So again, it makes us take a step back and really question what the underlying issues are there. Now, SIDS, or sudden infant death syndrome, is another smoking-related condition that pulmonologists, particularly pediatric pulmonologists, deal with. Now, SIDS is a condition where, for unknown reasons, young infants suddenly, usually during sleep, will stop breathing and will pass. Now, we believe that some of the underlying reasons for this are actually alterations in brain development, which prevent these infants from waking up when they are having respiratory difficulties. But other notable differences have been found within populations. So particularly, and many of you know this, so sleeping in the prone position, so stomach down, will place infants at higher risk for SIDS. We also know that family or mothers that co-sleep with their children place the infant at high risk for SIDS. And then also mothers who smoke during pregnancy and after pregnancy all are also associated with increased risk for SIDS. Now, what's interesting about that, many of those factors are increased in our African American communities. So of the children who have been identified as dying of SIDS related to prone positioning, greater than 50% of those children are part of black families. Also, mothers are more likely to, so African American mothers at a rate of 3 to 1 are more likely to sleep with their children in the bed with them. So again, placing them at increased risk for SIDS. Interestingly, African American mothers have lower rates of tobacco abuse during pregnancy and then after they deliver. But again, there's an underlying concern that even with that lower risk, our children are more susceptible to the risk of carbon monoxide exposure, et cetera, with their mothers or from their mothers. A couple other conditions. So we heard about sarcoidosis. Now, sarcoid is a condition that we still don't quite have a great handle on. We don't know the underlying reasons for it. It's a condition in which the immune system is dysregulated, and we get these, we call them granulomas, or small bumps that are present throughout the lungs and really can be present throughout the entire body. There have been found some mutations, particularly within chromosome number 5, within immune regulation genes that could affect our body's ability to stop these granulomas from forming. But regardless of the underlying reason, we know that African Americans are at a greatly increased risk of developing sarcoidosis, but not just increased prevalence of sarcoidosis, but increased morbidity and also increased mortality related to sarcoid. Now, when we take a step back, now that we've considered some of these disparities, one of the questions that we may ask is, how can we actually impact them? One way to consider this would actually be to consider from the individual out. Now, when we consider individuals, for you and I and any of our patients that are suffering from these illnesses, from a research standpoint, we think about the person, again, the underlying genetic issues, the underlying genetic predispositions, but then also the interactions that that person has with the environment that may worsen these illnesses or bring about these illnesses. Now, we particularly think, again, about the internal environment as well as the external environment. Now, internal environment, African Americans are at have increased exposure to particulate matter within their homes, so sometimes 100 times to 1. Now, some of this has to do with increased particulate matter and environmental pollutants outside the home that then become concentrated, either because of decreased ventilation or the desire or the inability to actually open up windows and increase ventilation. But regardless of the underlying reason, this is a potential area where we can impact. As far as the external environment, again, we already talked about the exposure, either because of high traffic as well as the surrounding industrial complexes. But this is a potential area where health policy can make an impact. And whatever health policy decisions are made will affect our communities, particularly African American communities, disproportionately, either in a positive way or in a negative way. We also then consider the interaction between our communities and the healthcare system. And as we've already heard, increased access definitely is going to be beneficial, but that in and of itself will not eliminate these disparities. We then have to consider, once we have access, what about the quality of care that we're receiving? And whether or not, and we already know that there are clear disparities there. So within the realm of asthma, black children with asthma are less likely to have asthma management plans or action plans. And we know that children with action plans are less likely to suffer from asthma exacerbations. Now, we also know that in the realm of asthma, children with asthma, really all African Americans with asthma, are less likely to use inhaled corticosteroids, and these are really the mainstays of therapy. Now, some of that, in truth, may be related to different physician practice patterns, but there's also evidence to show that our communities are less likely to be compliant with their therapy. Now, there are a lot of, when we consider the issue of compliance, there are a lot of reasons why individuals may or may not be compliant, and we can break those down into internal factors and external factors. But as far as internal factors are concerned, two particular issues seem to drop out for African Americans. So one is socioeconomic status, and the other is the desire or the readiness to actually take therapy. Now, if you consider both of those issues, it may very well come down to education. So one, the education that we're actually giving our patients, but then also education levels within our populations. Now that kind of brings us then full circle and makes us also then consider one of the points that Dr. Thomas brought up, which is our healthcare workforce. Because we know that African Americans or minorities in general are more likely to go back to the communities in which they came from to practice. And we also know that the interactions or the relationships that these physicians have with their patients are more likely to foster collaborative efforts where the patient would then be more willing to take advice and then heed treatment. So then how can we really focus on the the respiratory healthcare workforce? In my office back at the University of Colorado, this is something that we think about very often. At Colorado, we're in a very privileged position because we're the only major academic medical center for the entire state, but really for the surrounding states as well. So we have greater than 100 pipeline programs, which ultimately funnel a significant proportion of our students through. And when we consider sort of this pipeline issue, just to be very clear, we're considering from the point of primary education all the way through to junior faculty, because we know that our junior faculty members within academics are still at incredible risk at that level. Now, one of the concepts that we've been struggling with is how to actually help to guide our students through, because even though I was just speaking to someone a little bit earlier about the pipeline programs that they participate in, and I would imagine if I were to take a poll of individuals within this audience, many have either participated as mentors in some of these programs or went through them themselves. One of the considerations that we often think about is how can we really align the programs both in the state of Colorado but truly across the entire country. Because many times what happens, our students or our residents, our fellows, et cetera, go through these programs, and then what happens to them? We don't know, because we really don't have a way of tracking them, and we really don't have, even if we could track them, we don't have metrics to actually determine the efficacy of our interventions. So we're actually working on alignment of the programs that we have in an attempt to really get a sense for both best practices, but really the best way for students to go through. And we're considering this almost like an education home model, similar to a medical home model, where you have someone to help you and guide you through your educational course, much like a primary care physician would. So these are some of the things that we consider, and we hope that with these efforts we will have a meaningful impact not only on the respiratory healthcare workforce, but truly on the STEM workforce. And the reason why that's important is over the course of the next, well, even now, but definitely over the course of the next 50 years, the STEM professions will really be the most marketable. And as we think about the social determinants of health, particularly for minority communities, education and improving your socioeconomic status through education is incredibly important. So we think that by focusing on these areas, we will be able to make a significant impact. So with that, I'm going to pause there. I'm going to turn things back over to Audra.
Okay. Thank you. Thank you both. So I'm going to open up for questions, but if you don't mind, I'd like to just throw out a couple small ones for folks as they're gathering up their questions. I'm actually going to start backwards because you mentioned something, and I was just sending a message to my team to remember this for next year. There was not a panel here that I saw that talked about pipeline issues. Now, I'm an attorney, and I do a lot of work in Chicago about increasing the number of African American students in law school, not just getting them into law school, but also support afterwards. And with my colleagues I worked at Northwestern Law, my colleagues at Feinberg had an even more difficult challenge with increasing that number of medical students, getting them through their MCATs, supporting them while they're there, just a variety of issues. So I had it easy compared to them. So I'm just curious, in the work that you're doing right now, can you tell our audience a little bit more about some of your efforts to make sure that you are increasing the number of African Americans in med school?
Absolutely. So that's a terrific question. I think these are issues that many of us deal with, particularly those that are within academic settings. And it's very difficult, and I would be lying to you to say that we have all the answers. But what we do know is our efforts up to this point haven't been working. And what I mean by that, we put an incredible amount of money. So from the federal government to state governments to institutions, et cetera, we put an incredible amount of money into all of these efforts. So both from the standpoint of pipeline programs to recruitment, both for medical school, for dental school, et cetera. But if you look at, particularly for medicine, if you look at our numbers as far as the number of matriculants and number of graduates from medical school, it's been flat. Some of you may remember the WMC efforts from the mid-1990s, the whole 3,000 by 2,000 efforts. Now, although very well intentioned, we didn't get the end result that we were hoping. And we think part of the problem is, as I alluded to, alignment. So we can have one program focused on the primary education level, and that program may be fantastic. It may expose some of our students to what's out there, so be it nursing, being a physician, being a dentist, etc. But really, what then happens after that? So what's the next step? Now, it may then be 4 or 5 years later, the student participates in another program. Again, you're putting more funds, more energy into it, and you may have a peak of activity from the student, but then it may wane if those efforts aren't sustained. So really what you can't just have these summer programs, which again are fantastic, but you can't just have a summer program and then the student goes back to their home institution and still is left to fend for themselves. So you have to, and this is what we think about or talk about when we talk about the pipeline and leakage from the pipeline. And the pipeline in itself, to be honest, is probably a poor metaphor, because to be honest, when I think of a pipeline, it makes me feel very claustrophobic. But it is helpful because we can think about sort of different pipes coming together and how water or individuals can then leak out of it. So really the question is how to make it a seamless pipeline, how to connect all the different components. But in order to do that, you really have to have engagement of all the key players, all the directors of these programs, and have some sort of overarching body to help with the alignment. If not, then you'll just end up wasting effort, wasting both human effort as well as financial effort.
Could I? My question really piggybacks on yours. Again, I think thank the panelists for a very scholarly and well-referenced presentation. Really enjoyed it. In fact, I was going to stay, but I was so intrigued I had to go out and put more money in my meter. But I think I chair the Ward 8 Health Council, and this morning we were discussing the need for more African-American physicians in our community. We only have 2 OBGYN docs east of the river. And the question came up. They talked about all the money going into patient-centered medical homes. That's being interpreted as more FQHCs. They proposed 4 FQHCs in Ward 8. Well, we were telling them, well, as some of our physicians go out of practice, there's some buildings there, there's a practice base there that you could just use rather than build new buildings. Right. So again, it's such a critical issue for us here in the front lines that I really appreciate you bringing it up. I'd like to hear more about this in terms of fulfilling the need for closing the gap disparities from a patient-centered medical homes perspective as well. Thank you.
That's a fantastic question, and I will initially talk about that, and I'll let Dr. Thomas chime in. So I think your point is very well taken, and Academically, we also consider this issue, meaning that we have the physicians that we do produce. Many times they go out to the community, which is what we want them to do, but then we don't connect them back to the university. And the reason why that's important, in order to, mentorship is incredibly important. So I oftentimes say, again, you don't know you can be until you see it. And I know for me personally that was very true. I didn't even decide to go into medical school until I met the first African-American physician that I ever met, which was the summer before I went off to college. And that had a very profound effect on me, coming from an incredibly impoverished community. But if we don't have a way to connect these physicians that we are producing and have them serve as mentors then for the students that we're still trying to recruit and train, then we will continue to have this ultimately flat production. So one of the ideas then is to, instead of having the ivory tower, to truly connect with the community. And obviously that's important from a medical standpoint. It's important from a training standpoint, but also important from a research standpoint. So back in Chicago, Robert Wynn, who is the director of community affairs, I believe, at the University of Illinois, is actually doing work on this issue. So for the FQHCs, putting research back into the community and involving the patients, not only as far as enrolling them as subjects, but really having them take a ownership of the research itself. Because so many times we do research in the community, it ultimately gets published, but what happens to those patients? So they really need to then see the benefit and really feel as if they aren't being used then by the overall research complex.
Yeah, this issue of diversity in medicine continues to be an ongoing problem. We've been dealing with it for years. I was in a system where we had a magnet school adjacent to the medical school, and we were able to pull some students from the magnet school. It was a science-oriented magnet school. But that's, a small drop in a big ocean. I did mention the issue of pipeline, but Dr. Haynes said, and I'll read that last sentence again, over the long haul, the outlook is not encouraging unless we can have impact on the educational system as far down as the elementary level. I know that when many of us think about it, we think about trying to get them in college and have them participate in research activities with an experienced investigator who's sensitive to diversity issues. Yeah, that's good, but the pipeline is trickling by then. Mm-hmm. And then in the high school level, the magnet school helped, but not enough. Middle school is okay, but you really need to get to children before science becomes a pariah.
And I'll just interject and say that that's particularly important for men of color or boys of color. So African American boys get turned away from the STEM fields, get turned away from the sciences and mathematics at an incredibly early age. In fact, we can see the discrepancy, so the achievement gap, even as early as even as early as kindergarten in some instances.
Absolutely. I was just getting ready to give you this anecdote, and I'll give it to you. I worked in a prior life in Los Angeles, and I remember one time being asked to go to an inner city Los Angeles school called Crenshaw High School. They put out great athletes. Some of the UCLA athletes during the John Wooden era came from that. And I was asked to give a talk to a science class. Well, I went to this science class. There were about 38 students, one black male, and all the rest were women, black women. All the rest were black women. During my entire talk, the black male kind of, he did this, and most of the females were interested. They asked good questions and so forth. That is a major issue. A major issue. We've got to find ways to get down not just to the middle school level, to the elementary school level. And it's a daunting task because you have to at least have them realize that a career in science, an interest in science is something good.
Right.
One thing we need to do is to take people like Dr. Conwell and younger down to the medical school, young medical students out to these venues, so at least some of these students realize that at least people closer to their age made that decision. It's a daunting task, and it's something that I can tell you is an increasing concern to us. But as you can see, in 1969 it was a problem, and it continues to be a problem nowadays.
Can I make a comment about that? The Minority Affairs section of the American Medical Association conducts something called the Doctors Back to School program, and we're going tomorrow to 2 schools and present that they can too become doctors. Not only Latinos, but black kids, and we're going to go represent to them. We do this every year. We do it every time there's an AMA meeting. We go out to the schools, and we have at least 200 or 300 kids listening to us.
Yes, those things are vital.
Absolutely.
So, did you have a comment about the, I apologize, I didn't mean to, this is a sign that there's a panel that we were missing clearly, but I just wanted to make sure that I did address that before I steered things back to the presentation. Did you have a comment on this issue?
Yes.
Go ahead.
Congratulations for the presentation, and it was brilliant and enlightening. My name is Noel Cayo. I work for the NIH as a clinician for the SOUL study, which is study of Latino. I want to address the problem with the pipeline. There is no doubt that it's challenging to start from elementary school and to follow them and have mentor onto medical school. It's very difficult. That's probably one of the reasons that we have not been successful really to have a metric system and to have a follow-up. However, there are some African Americans who have managed to navigate through the difficulty of medical school and reach the level of graduating and have their board score and now cannot get residency. And there is really, they're right there at the door. What is being done for them?
So again, incredible question and very poignant question. I, again, believe this highlights the fact that the pipeline doesn't just stop once you get into medical school. It doesn't stop once you finish medical school or become a resident, a fellow, etc. It really continues on. So in a situation like that where a medical student has finished their courses and taken the boards, it may actually be then a board score issue. So again, this gets back to the achievement gap. The achievement gap that we see on standardized tests, it follows throughout. So it's present at the level of, again, elementary school when we think about the standard core testing. It's present at the SAT level. It's present at the MCAT level, at the board level, even through for faculty members. So what I would say in a situation like that, your efforts still need to be made for those students, because something like that should also be picked up earlier. So students shouldn't get to the boards, for instance, and fail on the boards, because more than likely there were issues during the curriculum, because the student has to take standardized tests through the curriculum. So someone should have been there to pick up that this is an underlying issue and then put measures in place to try and help them with the thought that this is going to come up again. So I think it just highlights that we need really a longitudinal effort, but really, again, a coordinated effort.
Yeah, I think that is an unfortunate reality. And I place a lot of the blame, to be honest with you, on the medical schools themselves. I believe if you're going to bring a student into the medical school, you need to provide them with whatever assistance is necessary to get them to the level, and the usual problem has to do with passing standardized exams. And so they spend all this time in med school, but then they get out and they can't pass the standardized exams that lead to certification. And I believe a lot of that responsibility is in the hands of the medical schools, and I think our medical schools are not doing a good enough job shepherding these people through. One other anecdote. I was at University of Michigan in the mid-'70s, and they had a program during that period of time where the federal government gave medical schools X amount of money, I can't remember what it was, to bring minority students, black and Latinos, into medical school and get them out. And they were allowed to do it in 5 years, okay? But the problem one of the problems that program had is that if the student failed in year 1 or 2, the school would still get the money for the subsequent years. Right. Now, that program worked. What's the name of the black physician, neurosurgeon who is
Ben Carson?
Yes, Ben Carson was a 5-year student in that program. His scores in high school were not great, and he was shepherded through the early years of Michigan, and he had the ability. Many of these students have the ability, but one of the problems is taking and passing standardized exams, and I don't think we in the medical community do a good enough job in helping them through these periods so that they can take standardized exams.
Great.
I think that's part of the problem. It's more complex than that, but test taking is a big part of it.
Can I and I know we have to move on to another question, but just to follow up with that, resources are also an issue, right? So we have multicultural affairs or minority affairs offices within pretty much every medical school or every dental school, etc. Even law school, I would imagine, has similar offices.
That was me, yep.
So, but unfortunately, many times these offices are under-resourced. Now, Martin Neve, the current Chief Diversity Officer for the WMC.
They're always under-resourced.
They are. So Martin Neve, the Chief Diversity Officer for the WMC, has really been pushing forth this concept of Diversity 3.0, which some of you may have heard of before. So this is really a business concept that was first developed by IBM a number of years ago. So it talks about 3 different operating systems or paradigms of thought for diversity. So the first operating system, or Diversity 1.0, was really affirmative action. So that included extended from the 1960s.
Nasty word.
Yeah. Well, from the 1960s up to the 1990s, and the main impetus for that was to correct the social wrongs, etc. But we all know then the backlash from over affirmative action during the 1990s. So then from the 1990s until present, we've really been in Diversity 2.0, which is the argument for diversity there is that diversity makes our entire class better. So by having diversity within our class, a few diverse students in our class, it makes other medical students, dental students, etc., better, more culturally competent, which is true. But at the same time, from a business standpoint, that places diversity as a parallel end. So for affirmative action, it was a competing end, and as a result, that's one of the reasons why it failed. For Diversity 2.0, it's a parallel end, but if it's a parallel end, it's still ultimately under-resourced because it's not key to the, or core to the mission of the institution. So Diversity 3.0 is sort of the paradigm shift that we're in right now, and it's this thought that it's a business argument for diversity, that diversity actually makes your end product better. So from a business standpoint, you could equate it to if you have a multinational or, a multinational company, and you're trying to market in South America and Southeast Asia, but your entire marketing team is from, the U.S. Northeast, then you probably won't be as competitive on the world market. But similarly, from a research standpoint, and definitely from a healthcare standpoint, having a more diverse workforce, we know does ultimately improve your healthcare outcomes. And by doing that, you make diversity key to the central core of the mission, and you give resources that are then needed to ultimately accomplish what you want to accomplish, such as making sure your students make it through successfully.
Thanks so much, Dr. Conwell. And I know that I was the Director of Diversity Education and Outreach and had a staff of 1, which is me. So I understand.
Usually that's the way it is.
That's the way it is.
Yep.
We have 10 more minutes for questions, and again, this is clearly a panel that we need to have separately, but I do want to make sure that we're able to also touch on our issues that were raised by the panelists. And I will let our next question, I hope someone will ask something about national campaigns for awareness, but what do you have?
My question has to do with asthma and the way it affects African Americans. Because I've always thought that asthma was, you know, you have an acute phase, I mean, you treat it and then you're okay. I had an experience recently in terms of my son was an asthmatic from a child and had health care, good health care, but now he's in his 40s and his physician tells him, well, your lungs look like COPD. You know, his pulmonary function tests are very poor. Is that something that you see in African Americans particularly?
So that is a wonderful question. Actually,
Wait a minute, before you answer that question, Ms. Henderson is a former head nurse at Howard University Hospital. I recognize her really well.
Small world. So that's a wonderful question. And actually, I apologize. I was going to comment on that exact issue when I was up there, but I forgot to do so. So COPD in general, we consider that as emphysema and COPD and chronic bronchitis. But if you have longstanding asthma that's undertreated, it becomes, so asthma is defined as reversible airway obstruction. It's a chronic condition, but in general it's reversible as far as the airway constriction and the inflammation. But if it's undertreated, over time it becomes irreversible. And when it becomes irreversible, when we look at it both by pulmonary function tests and by CT scans, it's indistinguishable from chronic bronchitis. So you see thickened airways, chronic obstruction. So in a situation like that, one of the issues would be how aggressively he was treated when he was younger. And unfortunately, what also happens, because there is tobacco exposure, both firsthand as well as secondhand, and as I mentioned, African Americans may be more susceptible to those effects, that may also then play a role in the pathophysiology. So it's definitely one of those things that we see very often, and so much so that many times we end up just calling it asthma/COPD, or we just call it COPD, because there's no way for us to tease out what the underlying pathophysiology was, because now it all looks the same.
Thank you.
Yeah, there's been a dispute and controversy in the pulmonary community for years between those who thought asthma was a separate disease and not part of the continuum to COPD, and others that thought asthma could proceed from the continuum of pure asthma to COPD, and inflammation is part of it. And over the years, particularly if there's not been aggressive enough therapy at appropriate times with corticosteroids, there can be scarring in the airways and chronic changes that look more like COPD than asthma. The issue about ethnicity and asthma, particularly at the present time, 1 out of 9 African Americans in this country have asthma. 1 out of 9. And that has increased substantially over the last decade. It's not completely clear, but they're beginning to find genetic polymorphisms that where blacks have more trouble, in particular blacks, have more trouble with asthma than others. They're more resistant to corticosteroid therapy. And even in the Latino community, community is not a homogeneous community. Right. Puerto Ricans in general have a very high incidence of asthma, even greater than African Americans. And I think these things will be worked out more clearly by looking at environment as it relates to genetic susceptibility over a period of time. But it's not completely clear.
You know, that one follow-up point about that, Puerto Ricans are incredibly interesting as far as the risk for asthma, but what also is interesting then are the environmental risk factors, because what we see, rates of asthma in Puerto Ricans are highest for those that are living in Puerto Rico. But then as they migrate to the United States, their rates fall, or they're still the highest, they have the highest proportion out of any group in the country, but there's definitely then an environmental component as well.
Okay. So we have time for 2 more questions. I'll take the last 2 of you.
Thank you. Hi, my name is Cassandra. I'm an OBGYN resident in Syracuse, New York, and I want to thank the panel for your comments. My comment is based off of the built environment. So I have have my master's in public health that pretty much focused around that. So I'm really glad that you brought that up as a topic of discussion. My question is, one of the things that I've struggled with through residency is trying to figure out how do I use my MPH to kind of make the most impact. And one of the things that I do is get involved in things like this, being a part of conversations and then being an advocate. What are some of the ways that we can try to educate the regular, or I should say the general population of physicians to know that there's a connection between the two? And the reason why I say that is because I've done research. I'm a pipeline kid, so I've done a lot of research in different areas. And one of my research projects was to actually go into a home with somebody that had diabetes, and just going into somebody's house was eye-opening of itself. And I think that there was some benefit and value in the older days of doing home visits, because you got to see a lot of what those patients were living like, and it's different from what they show you in the office, because in the office they come nicely dressed and they're well prepared to be that perfect patient, as perfect as they can be for you while they're there. But then when they go home, they go back to that same environment. And sometimes patients or sometimes physicians don't necessarily see that aspect of it, and then they don't see how they can help them outside of the office.
That's a great question.
Yeah, I think it's very important and to reach this community involvement. That's why I quoted that recent article in the AMA Journal. The cardiologists, the hypertension people dealt with this problem years ago. They had what were called lay workers. They had people from the community that were identified, that were in the community, they were used to train and educate community members about the issues of hypertension. They went into the churches, they went into the homes. They were trusted. This quote I used talked about the issue of trust. I think if you're going to reach out to our community, the Latino and the African American communities, it's got to be done at the community level. One of the problems is it costs money. There are foundations out there that are interested in being involved, but I can tell you, until we have adequate Medicaid expansion, that's going to be a problem. But we must be reaching out to the community and training people in the community to give the education that we think that they should have. The other thing is, I think the increase in the numbers of people in the formalized health system now is forcing us as physicians, actually I can't say physicians led this process, health policy people, to realize that we need nurse practitioners and physician assistants out in the communities also, that they're willing to reach out into the community more than physicians. I think a combination of these things, and probably many other things that people will think about in the future, will work eventually. But we must have at least Medicaid expansion so these people can have insurance, and clearly some dollars have to be moved in those directions. I could make a political statement here, but I won't.
And then I also want to just touch on the comment that you made about career, and particularly how to use the skills that you have to impact not just your patients, but then also those individuals that you're working with. And I would say this is definitely a double-edged sword, because you have many skills right now, and you want to use those to the best of your ability. But many times when you're the only one or one of few within environments, so at the residency level and at junior faculty level, et cetera, you're going to be pulled in so many different directions to serve on this diversity committee, to serve on that committee, et cetera. But if you choose to stay in academics, you're still going to be required to do all the other stuff that you need to do in order to ascend, so all the other promotions pieces. And we oftentimes refer to this almost affectionately as sort of the black and the brown tax. So it's those things that are required of you, expected of you, but aren't rewarded, because all the social, et cetera, endeavors that you have wouldn't be rewarded in the promotions process. So this is really something that you have to be very careful of. You have to know when to say no, and that's something that at a very early age, as far as where we are, so residency, fellowship, et cetera, can be hard for us to do, but it's incredibly important for your career survival, because really to have the impact that you want to have, you're going to need all those skills that you're accumulating right now, but then you're also going to need to get to a level where you can really have a greater impact, because you could mentor a student, you can participate in that program, et cetera, but that will be a very limited effect. But if you are a senior faculty member, you're doing research in this area, you're now a local, national, international leader in this area, you could have an incredible impact down the stream. So you have to be very careful of, so you never let your passion go away, but you have to be very careful at what point in your career you actually choose to go after some of these other things.
Hello, my name is Lily Reagans Walker, and I am an adjunct professor at Morgan State University. I was a nurse since 1960. I graduated and then went back to become a clinical social worker. And my question is, I see that under the chronic obstructive pulmonary disease, you list sarcoidosis. And sarcoidosis is one of those kind of diseases that I really know little about. However, I have two sisters who have been diagnosed with that. And just recently, my eye doctor was treating me for my eyes. And she said, go get an x-ray because you may have sarcoidosis. What is sarcoidosis? How does it manifest itself? And could I possibly have it? And is it something you can get rid of once you get it?
That's a very good question. So taking a step back, sarcoid is the problem is we don't know a lot about sarcoid. So even though there's a lot of research that's been done, it's a bit of a mystery. But we believe it is a condition where the immune system is dysregulated. It's not doing what it's supposed to do. And it may have an autoimmune component. But what's important for us to know within our community, within African American communities, it is very prevalent. It can affect multiple parts of the body, so definitely the lungs, the eyes, the brain. But there also appears to be a familial component where, particularly for African Americans, and this isn't true for all other races, but particularly for African Americans, if you have sarcoidosis, it increases the chance that a sibling will have sarcoid twofold. So definitely if you have siblings that have sarcoid, you want to do what's appropriate, particularly if you have symptoms that have developed. But what's also important for us to keep in mind is the vast majority of patients with sarcoid, so greater than 50% of patients with sarcoid actually never even know that they truly have it. And what I mean by that, it's many patients are self-limited. So it will come on and will actually regress on its own without any intervention from us. But for those patients who their sarcoid doesn't regress on its own, they can have a more protracted course. And that may require numerous doses of prednisone, so steroids in order to keep it under control, and then also routine screening, not only with x-ray, but with the eye exam as well. And then also EKG, because some patients can actually develop heart arrhythmias. So what I would say, if you have family members with sarcoid and you have symptoms that could be concerning, so particularly if your ophthalmologist has told you that you have some concerning eye changes, absolutely go get checked out. It may not mean that you need treatment for it, but you definitely need to be followed over time.
Thank you.
Yeah, sarcoidosis is a disease that involves mainly the fleshy part of the lung and not the bronchial tubes. It's not really an obstructive lung disease, even though when it's been in the lungs for a long period of time, it can distort the bronchial tubes and act that way. In the patients that we see with sarcoidosis, it predominantly involves the eyes, the lungs, and the skin. and in many patients, well, and it's known to be prevalent worldwide. It's the Japanese have problems with it. It was originally described in Scandinavia. It occurs in Europe, in whites and non-whites, but particularly in this country and other countries too, it seems to be more of a problem in blacks. It's more like in Caucasians in this country, they may get it for a period of time, may or may not have treatment, and then it goes away and stays away. But African Americans in this country, they can get it, be treated, it gets better, and then goes away. But there's a hard number where the disease can progress silently over a number of years, and it's particularly important to follow those patients over a period of time, because medications do help ameliorate the disease, doesn't cure it, but helps reduce the problems that occur with sarcoid. But the eye problem is very treatable. They have steroid drops they put in your eyes, and usually what happens, we get a lot of our patients referred to us by patients who wind up with skin problems, and then the dermatologist biopsies and sees characteristics of sarcoid, or the eye doctor, they have problems with their eyes and they see this problem called uveitis, and they know that uveitis can be caused by a number of things, but one of the things that can particularly cause it is people with sarcoidosis. And so they'll see the uveitis, they'll send the patient to us. Patient doesn't have any respiratory symptoms, but we get a chest x-ray and we can see evidence of signs of the disease. But it's treatable. At this point, it's not curable, but in many patients, even African American, it may still go away and never come back, but it can persist. And so you need to make sure you see eventually, in addition to the ophthalmologist, a pulmonologist, get an x-ray. If the x-ray is not normal, then that doctor needs to evaluate you and then follow you over a period of years, usually not more than 2 or 3 times a year, and for a number of years.
No. So sarcoid is we believe that it's a 2-hit model, so meaning that there is an underlying genetic component to it, but there we believe is some sort of environmental component that then causes it to come about. And is that a virus? Is that a bacteria? We don't know. But as far as we know, it's not a condition that is actually spread from one individual to another.
No, it's not contagious. For a long time, people thought early on that TB was causing it, right. But that was proved to be wrong. But one thing is true: in many people, there's probably some exposure. We use the term antigen. In other words, something you're exposed to in your environment. And I think, no, that may be cats. Cats and multiple sclerosis. But anyway, that you're exposed to in your environment, and for some reason, with your genetic makeup, that exposure results in a disease like sarcoid, as opposed to maybe 95% of the population that would have that exposure. Their body would adjust to it and they would never have a problem. But that's as much as we know. We don't really know the cause, and it's probably going to turn out to have multiple causes.
So in the interest of time, and thank you so much, Dr. Thomas and Dr. Conwell, we have to wrap up. If you just have a final word, it was just one thing I wanted to make sure, and again, because we got off on a very important tangent about diversity, but the last question when she mentioned sarcoidosis had a question I meant to ask you earlier, maybe you could end on this, and that is, when we talk about these national awareness campaigns, obviously there's been a lot to talk about asthma. Now I'm in Chicago, so I happen to, one of the folks we worked with is the Bernie Mac Foundation to talk more about sarcoidosis. But what's happening on a national scale to bring more attention to our communities to answer these sorts of questions about sarcoidosis, COPD, some of the respiratory ailments that we don't hear quite as much of? I'm just kind of curious if there are more coordinated efforts to be able to raise awareness, as we see in this room, that there's not as much awareness about some of these kind of lesser, not lesser in terms of severity, but lesser known ailments.
So I'll actually defer to Dr. Thomas and the ATS as far as what the ATS is doing.
we've been dealing with a lot of problems for a long period of time, and one is marketing our profession and helping people to understand what the various diseases we treat, what they're like. I mean, we've had trouble for years explaining what COPD was, chronic obstructive pulmonary disease, and lo and behold, the pharmaceutical industry are the ones that helped us begin to solve that problem, because I think all of you here, and certainly all of my patients, some of them that don't have computers or don't refer to computers a lot, they know what COPD is because they see the pharma advertisements on television. Now, they may not know a lot more about it, but at least it opens up the lane so that I can at least try to explain to them what it is. I don't think we do as good a job in marketing our profession as cancer and heart, mainly because we don't have, and I'll use this term lightly, a sexy illness that we can put up there. That's why a lot of times you see us, even though a lot of us are adult physicians, you'll see a child with asthma because people can connect with that. And we try over the years to get spokesperson. By the way, Leonard Nimoy,
Mr. Spock.
Mr. Spock.
He died from COPD. It wasn't for some reason they don't the patients don't say, well, I had COPD like the heart people or the cancer people, where they're more willing to talk about it. I think that's an ongoing process. The various committees I sit on national level that we're very concerned about making some headway, but obviously not good enough.
Well, Dr. Conwell, would also address the blame issue. You just mentioned something. Yeah. There's a difference between having asthma as a kid and someone who smoked for 40 years.
Exactly. So that's exactly what I was going to say. So there's a stigma that's attached to many of the illnesses that we take care of. So particularly the smoking-related lung illnesses, where the underlying stigma is, you did this to yourself. And as a result, both funding for research in these areas, particularly lung cancer research, COPD research, et cetera, falls far behind other areas. So particularly breast cancer, prostate cancer, and things like that. So I think part of it is actually then detaching that stigma. So one interesting thing, so even though tobacco is the primary cause of COPD here in the United States, worldwide the primary cause is actually biomass exposure. So we call this hut lung, quote unquote. So
and biomass exposure is?
Yeah, so biomass exposure is essentially when you burn different carbon-containing fuels. So that could be wood, it could be in some parts of India, dung, things like that, and you burn it in a way that it's not ventilated well outside. Those particles that you then inhale will cause COPD, just like tobacco will. And what's interesting about that then, one, we're seeing a lot more of these patients as they are immigrating from other parts of the country, and they're primarily women as well, because they're the ones in the house cooking and things like that. So I think it's important to really, yes, from a marketing standpoint, put a different face on it, but then also, I will say one of the dirty secrets that pulmonologists don't share is the majority of patients who smoke actually will not develop COPD, nor will they develop lung cancer. So again, we don't share that because regardless of the way you look at it, tobacco isn't good for you. But I think it's important is to actually take a step back and really look at COPD as not just a smoking-related illness, but really an illness that can affect multiple people with multiple risk factors, but then also affect children and other people who are exposed to secondhand smoke, which really isn't, quote unquote, their fault.
400,000 people in this country every year die from smoking-related diseases, and only a small percentage of those are respiratory. The majority are cardiovascular and cancer. 400,000. I remember giving the statistics years ago. That's more people in a year than the combination of all the wars that who have died in all the wars that we have fought in this country. And it's like alcohol. it's so prevalent. We're doing better in this country, but you solve the problem in one area and you think you got the cigarette companies down, and they come with electronic cigarettes. And, they're always coming up with something.
Thank you so much, Dr. Thomas. And thanks to our panelists. If we can give them a round of applause.